Well, good morning, everyone. My name is Deirdre Roach, and I serve as a medical program officer at the National Institute on Alcohol Abuse and Alcoholism in the Division of Treatment and Recovery Research. On behalf of the Interagency Work Group on Drinking and Drug Use in Women and Girls, I'm delighted to welcome you to our third webinar in 2024. Thank you for joining us. The Interagency Work Group includes representatives from multiple federal agency partners, academia, and healthcare provider organizations who are committed to improving access to evidence-based mental health and addiction prevention, treatment, and recovery services for women and girls across the lifespan. In today's webinar, Mr. Robert Vincent will address investing in our nation's children, supporting student behavioral health and resiliency. Mr. Vincent serves as the Associate Administrator for Alcohol Prevention and Treatment Policy for the Substance Abuse and Mental Health Services Administration's, or SAMHSA's, Center for Substance Abuse Prevention, Office of the Director, leading and managing programs to reduce underage drinking. As the Associate Administrator for the Prevention and Treatment Policy and Staff Chair of the Interagency Coordinating Committee for the Prevention of Underage Drinking, known as ICCPUD, he serves as a subject matter expert across the federal system to build consensus for a coordinated federal approach to the development and implementation of policies, programs, and practices that prevent underage drinking and other substance misuse. Rob has worked in the area of substance abuse prevention, intervention, and treatment for more than 36 years. Prior to coming to SAMHSA, he served as the administrator for True North Student Assistance and Treatment Services at the Educational Service District 113's Department of Educational Support in Olympia, Washington. Rob was responsible for the development, implementation, and management of a 45-school district consortium operating school safety and substance abuse prevention, intervention, and treatment programs within the 5-county region. He has served as a past president of the Washington State Prevention Certification Board, a nationally certified clinician, and as the director for counseling and assistance programs for the U.S. Navy during Desert Storm. Rob was the principal investigator of the Olympia Effective Adolescent Grant and has served as a consultant specializing in the implementation of schools-based prevention and treatment programs for several states. He received his Master of Science in Education degree from Southern Illinois University. Today, Mr. Vincent will provide an overview of federal resources available to community service providers working to build resiliency among children at risk and living with mental health and substance use disorders. Please feel free to submit any questions you may have in the chat box or to use the raise hand icon after the presentation. Rob will address as many questions as possible immediately following his formal remarks. Please join me now in welcoming Mr. Robert Vincent.
Thank you, Deidre, and welcome to all. I am very pleased and proud and feel privileged to have the opportunity to talk with each of you today and to share a little bit of information. I'm hoping that it's helpful. I will try to be as concise as possible, as I know, it's important. The work is important, and let me just start with that. That is where my heart lives in all of this, is that I think we could always do better for our nation's children, and so you'll get the flavor of my thoughts on all of that as we go. So, as Deidre said, investing in our nation's children and supporting student behavioral health and resiliency, this is some work that's very near and dear to my heart. And what I hope to do with you today is really share a strategic vision for a coordinated approach for school behavioral health services broadly, to talk about a few updates and progress on patterns of mental health and substance misuse and abuse, indications of treatment, etc. And then really some trends across the continuum, both of prevention, and you'll notice I added intervention, because intervention is a little bit of the gap in the system, but also treatment and recovery. And then discuss some priority initiatives and behavioral health challenges broadly. Now, I'm going to make an assumption here, and we all know kind of what that usually means. But I suspect many of you have been looking at the data, in particular for girls and women, for quite some time. But I think it's worth noting kind of where we're at with a few things. That, I want to just sort of set the stage for the discussion that, survey after survey really underscores the need to really intensify our collective efforts around behavioral health needs for our nation's youth. About 33% of the individuals 12 to 20 have consumed alcohol at some point in time in their lives. Now, I want to put that in context, given that there are approximately 4 million children born every year. So that means we have a pipeline of new children that we need to be thinking about how we prevent and protect. Approximately about 3.3 million youth, sorry about that. About 21% of the people over the age of 12 reported last year marijuana use. And that's an increase of 37% among the 18 to 25-year-olds. So we can see where the trend lines are going a bit here. From 2013 to 2023, the percent of high school females attempted suicide, that was an 11 to 13% increase. And then from 2009 to 2019, the proportion of high school students reporting persistent feelings of sadness, hopelessness, increased by 40%. Now, we can put that all in the context of how many children are actually getting and receiving services. And less than 5% of our young people, 12 to 17, are receiving the needed substance use treatment services they need, and only about 34% for young people receiving mental health services. So you can see where there's a sort of a gap in the system. Now, all of that said, SAMHSA has a pretty large equity in all of this. We contribute about $1.5 billion to the system, both mental health and substance use, specifically targeted at youth. Probably our largest on the substance use side is our substance use block grant. That particular grant has a 20% set aside for prevention. And of course, the treatment side of that funds the preponderance of substance use treatment really in the nation. Although we're starting to see more with the Healthcare, Affordable Care Act and other things, larger equities in that, it's still difficult to access some of that. The group that probably lost the most in that transition was youth. And we can talk more about that. So, and of course, you can see our mental health block grant. Some of the key programs that SAMHSA has been very involved with, specifically towards youth, is our strategic prevention planning framework. This is broadly a prevention strategy, really state and community based, to really affect policies, programs, and practices broadly in the space of prevention. Our sober truth on preventing underage drinking, or what we fondly refer to as the STOP Act, which is sort of the home of the ICCPUD. So that's sort of our group in that respect. My colleagues at CSAT have the youth and family, what they refer to as the TREE grant. The state implementation, or our state youth implementation grant, which is a large statewide implementation grant at CSAT. Now, many of you have probably heard of screening, brief intervention, and referral to treatment, or what's fondly referred to as SBIRT. Our PPW program and its pilots, our Children's Mental Health Initiative, Project Linking Action for Unmet Needs, or Project Launch, from our colleagues at CMHS, our National Traumatic Stress Initiative, or NTSI, our Children's Mental Health Initiative, or CMHMI, and then probably one of the more popular ones out of CMHS at this time is Project Aware. And you can see the Aware SEA, which is the state educational authority. And so all of those programs are really targeted towards youth and adolescents. Now, in that same frame, I want to just speak to sort of the front end of the system just a little bit. And prevention really does often serve as the front door for behavioral health services in ways that sometimes don't get very well accounted for. When we think about policy assessment implementation, those are all critical and key in preventing and reducing substance use disorders and mental health conditions. Primary environmental prevention strategies, this is sort of the universal prevention strategies that really sort of get population level effects. but also screening, identification, and referral for services. How do we get those individuals that we're concerned about or we care about or our priority population? How do we help them get to services when they need them? And we'll talk a lot more about that as we get going here. But also, how do we build parent awareness and skill building? Lots of our prevention programs are very focused in those spaces with our community coalitions and school prevention programs and statewide implementation of various programs for prevention, including school-based prevention or student assistance, as I fondly refer to it. Warm handoffs and both for mental health promotion and suicide prevention. Many of you are very aware of our 988 efforts. Our 988 team has done an amazing job with all of that work, but also building community awareness. How do we help communities become aware of when there's a problem and then start to think about how they might start to address those problems? And then community-based education, which is a part of that, but many of you might be aware of our naloxone saturation grants and some of our efforts to in the opioid space. And then lastly, community linkages. So things like harm reduction, recovery supports, ongoing supports, those kinds of things. And all of that is really in part the primary role or the front door of the system, if you will, on the prevention space. As you heard me talk a little bit about our Black grant, I thought it would be important. A lot of people really don't know, especially on the prevention side of the Black grant. Many people are very aware of what we do in the treatment side, but not as aware of what we do in the prevention side. And the primary approach here as a part of our Black grant is really centered around 6 key strategies: information dissemination, education, problem identification and referral, which includes student assistance programs and employee-assisted programs and early intervention kinds of things. Building community capacity, both within schools and community training teams or more systematic implementation, and multi-agency coordination and collaboration, much like what we're doing here today, both with this interagency work group, but also with the Interagency Coordinating Committee for the Prevention of Underage Drinking, operates under a very similar kind of process. And then, one of the other things that's important is really addressing community norms and policies. And, policy work is a very, very challenging area to work in. And, for those people who are hoping for sort of immediate change, you might find yourself a little underwhelmed in that space, because in many cases, policy is a 3 to 5 year and sometimes 10-year process to actually implement policies and see them implemented well. I would also note that in the policy space, programs to reduce underage drinking or the work under the STOP Act really has an amazing slope over the last 3 decades. And we would largely attribute those successes to policy efforts, the 27 policies that we evaluate and review every year in the State Performance and Best Practices Report, but also things like the ICCPUD Policy Academy. SAMHSA has been running policy academies for either naloxone saturation. And this upcoming year, we're anticipating to run another alcohol policy academy. And this year, I believe we're hoping to include medication-assisted work in that same space. So you can see all of that. And I would just mention one more aspect, and I'll talk more about this as we go. Within the policy realm, it serves little purpose to have a really great program and nothing to support it. In many cases, what happens is those programs fail because they're not really supported through policy in a way that allows them to be successful and maximize to their best effect and availability. Now, I think many of you are probably quite familiar with sort of our NISDA data. This will give you what it's looking like in the area of initiation for those under the age of 21. You can look under the alcohol space there, and you can see where that number is a little larger than everybody else, which, for me suggests that we're still in the same space we've been. Although, as I understand it, in the new release, I think for the first time, cannabis or marijuana has surpassed alcohol. But you can see where alcohol has still been widely, for most of its time frame, the substance of first choice with our youth. Now, as we sort of drill down just a little bit by gender, we wanted to give you some information that might be useful. This also comes out of our report to Congress, our State Performance and Best Practices report as well. But you can see adolescent, young adulthood, 26 to 29, middle adulthood, and then older adult, kind of the status of sort of alcohol consumption patterns by developmental period. And this really is from 76 to 2004 when we took a look at that work. Carrie Keith, some of you may know, she's an IEEE researcher and has done an amazing job with us in many respects, provided this data for us. But you can see across the span where sort of the adolescent side, it's decreasing on males and decreasing for our females. But what is interesting is that our young females are decreasing. Our males are decreasing faster than our females, so which is sort of an interesting stat. Our young women have caught up, but I don't know it's in the ways that we're all hoping for. But as you come across that, you can see our 26 to 29-year-olds, where we're seeing an increasing pattern. Now, part of that developmentally, one might expect. That said, I think it helps us really put into frame what our work is. What should we be doing to really support healthy choices, those kinds of things that sort of increase health, wellness, and well-being for our young people. When we think about past month alcohol use by age and gender, you can see the data here as well. And you can see our females, they're represented in the yellow, are still higher on all scores, including the 12 to 13. So you can see where, you know, we have some work to do in that space just yet. You can see, you know, in our 18 to 20-year-olds, which are still underage drinkers, we're about a third of individuals who are involved, and in many cases harmfully involved. So it causes us to pause a little bit. It keeps us certainly in our interagency meetings having robust conversation about what to do and how to best do that work. Now, I'll apologize for this one slide. We couldn't quite get the special run date graphic quite up to date there. So you'll see where that yellow line that goes across the side is not quite right. But I thought it's worth just noting to put it in context that the average annual percentage rate, 12 to 20-year-olds with DSM-5 alcohol use disorder. Again, 5.5% of those 12 to 20 had an alcohol use disorder. 13% had a substance use disorder. But you can look across states, and in our State Performance and Best Practices report, you can see this, how states are doing largely, and that really is the purpose of the graphic here, is to sort of help you put that in context. You can see where there's more work to do in some states than perhaps other states. Now, that's not to take anything away from a state that's doing an exceptional job. We probably shouldn't take our foot off the gas pedal at that point. We should keep working in the same way that we always have. Otherwise, we tend to lose ground. When we think about alcohol and substance use disorders, again, you can look at our 18 to 25-year-olds and see where that is. If you look at the far side on the substance use disorder, that's combined. You can see where that's 27%. But you can see for the first time in our 18 to 25, or I shouldn't say for the first time, but our 18 to 25-year-olds are still in the drug use category a little higher now than our alcohol use disorder. And so again, we're starting to see some shifts. It will be interesting to see long-term how that plays out. We are keeping a pretty watchful eye on all of that to see what we need to do next and how that might affect programming. Now, you heard me talk about the behavioral treatment landscape for just a minute, and this is a slide that's a little difficult to update, so I apologize. It's last year's data. There's been a resort in that data, and once the team has enough time to get this done, we will get it done and get you a new slide. But when we think about perceptions of need of substance use treatment from our 12 to 17-year-olds for the past year, you can sort of see there's about 9,000 during that period that sought treatment, 49,000 or 2.8% that did not seek treatment but thought they should get some. But out of a 1.8 6 million adolescents that really had the need for substance treatment, the preponderance didn't receive it. And that's a hard slide. The data in the new data set hasn't actually changed. It's been resorted so that it more accurately presents the effort, but the same challenge exists in the system. There's a lack of capacity, and that there are significant disparities across this system. For our adolescents in particular, and that the system as it exists today has largely focused on adults. And I certainly take nothing away from our adult colleagues in that space. That said, I think if we want to be more successful, we might want to be earlier in that conversation. And we'll talk about that in just a minute. In that same space, when we look over the last 10 years, those under the age of 18, so the system, and I'm just talking about the system, there's a 54% decrease in receipt of any substance use treatment. So, you can see that was 82,000 people who were receiving treatment down to 39%. So the pandemic certainly had some challenges for us, caused some delays, challenges in the world of adolescence. We had a lot of adolescent treatment facilities close and fold. When we think about our outpatient treatment, about 50% declined. Which, it's hard. Outpatient treatment really is probably the first treatment that most young people would get. We often don't send them straight to residential, but sometimes that could be the case. But when we look at residential treatment, you can see that declined by 67%. So all of this to say that there's been huge declines in the system. And that really presents very difficult if you happen to be a parent, caregiver, school administrator, community member who's working with a child in need. Identifying the need is very problematic if there's no place for them to go. Now, in that same frame, when we think about adolescents entering treatment, multiple comorbid conditions exist, and that has been consistent since really the work of adolescence had begun. And so that means that we have to have more integrated systems, more on-demand systems, and more systems that are better tailored for individuals at different levels that have comorbid conditions that are existing. Research has really demonstrated pretty clearly that if we can prevent and intervene before the age of 15, we can take decades off. In fact, the actual number is 27 years, but as much as 2 decades, nearly 3 decades, we can take off the substance use career of an individual. And I'd like to just dwell on that thought for just a moment. If we can get there early in this conversation, that means we could prevent a substance use disorder. It means that we could increase productivity, health, wellness, and well-being of our individuals, and quality of life significantly. This could mean the difference between I got involved in substances early on, and let's say I wanted to be a new young tech person, but this particular job requires a security clearance. Well, the likelihood of me getting that job is now pretty slim. As we see the stakes getting higher and higher in various jobs around security clearances and some of those things, then all of this sort of impedes on some of that, and all the more reason to help young people make different choices and fully be aware of that and to intervene early in that process, not to mention the cost to families and communities. And that in 2010 dollars, that was a $249 billion issue. In 2023 dollars, that was a $323 billion issue. So all of that to say, it behooves us to really get to this conversation much earlier. Now, as it relates to adolescents, and because I'm a former schools person who ran behavioral health programs in schools, we virtually start with nearly 100% of all children start in school. Part of the problem is we lose a lot of them, but more than 90% of them are still in schools. So that sort of makes it really a logical place to think about how and what we do in schools, and to think about what kinds of programs can be placed there effectively that help schools, don't overburden teachers and educators, or ask them to do work that they're probably not well trained for, which may cause us to rethink about how we deploy those programs and what those programs are. Now, from my perspective, just looking at the data and thinking through it all, for me personally, it causes me to pause and think for a minute. So how do we find our way forward? How do we help the right child get the right service at the right time? And largely from my frame, or at least what I've seen in my 36, almost 37 years of professional work in this space, is that we really do need to increase behavioral health services across the system, but in particular in schools, I think represent a good opportunity. That said, they need to be pretty well organized, and that's not always the case, and there's not really always an articulated, organized way for that to happen, which means that they need to be coordinated both at the state and federal strategy, a specific focus on schools, maybe even a parallel system, so that we're not asking teachers and educators to do skilled behavioral health work or that kind of work that they're not qualified for necessarily or credentialed, that may or may not create a barrier to clinical care or could actually impede on our prevention outcomes because we're holding on to children thinking we're doing good prevention when that's a child that really needs to be referred, for more acute care or in need of treatment services, but for whatever reason, we're providing life skills or some sort of prevention programming, which is probably well beyond the scope of that young person. Which sort of leads me to the idea of better identification and referral practices. These need to be coordinated through systems. Student assistance programs, Safe Schools, Healthy Students, Project Launch and Aware. All of these programs have a really good track record of doing some of that, but it really is incumbent upon all of us to really think about what that looks like and how we do that. What we know really hasn't worked very well are single-focused programs or short-term and short-time limited funding and grants. We've built a system largely on discretionary, and discretionary grants are excellent grants to get things started, but I don't think we want to think about our system, and as a person who wrote these grants for decades, you're perpetually chasing the money, and I think that creates disparities across the system, as well as uneven distribution across the system. Unstable funding sources and structures, in large part, I think I would attribute to why we don't see more adolescent care. Now, I have a little bit of it, and I just have to confess, I don't like the term at risk. I've never really cared for it, but I do think there are priority populations that we should all be thinking about. And right now, if you're to ask me, I think our girls in particular, but that would be true of women as well. As we think about alcohol, that's certainly a population we should be thinking and leaning forward into what we're doing and what we can do there. But as it relates to student assistance and school programs, those students who are experiencing academic or substance use, mental health issues, should be priority populations, groups that we should be thinking about how we provide additional assistance, reduce barriers, and help them thrive and get access to resources that will help them continue their track down their academic pursuits. I also think it's worth noting, and I used to say this all the time in my old home state, Washington State, that is, that you could be Washington State's best educator, but if the child in front of you is not available for your good instruction, then the likelihood of you being successful in teaching that child is diminished, and in some cases may not even exist at all, depending on the acuity. So it behooves us to think deeply about that so that we can make sure that, one, good teachers have a chance to impact children in positive ways, and two, that a child is present and available for your good instruction. I think we're all pretty aware of this, but stigma really disproportionately influences a lot of health outcomes. Suffice it to say, there are a number of ways that we can address this, but it means mostly having a will, as it applies to sort of school-based programming or student assistance kinds of things. Many of them work across our community coalitions and have really a very nice demonstrated track record in reducing stigma. That said, it's alive and well. In fact, there's really no single policy, program, or practice or effort that single-handedly can eliminate this issue, which really sort of begs the kind of work that this group is doing every day in terms of how we address this, how we have these conversations meaningfully, how we help people see the importance that really every child has the right to thrive and be successful. Now, let me just turn to the work of some of the work of the ICCPUD and SAMHSA in this space. And for the last several years, the last 4 years in particular, the Interagency Coordinating Committee, or ICCPUD, has really focused on this idea of alignment of our public health messaging with intervention. Now, we run a national adult-oriented campaign, so it's not a youth campaign. This is adult-focused. The idea here is to strengthen adults so that they can have conversations, be present, intervene, be supportive, etc. Largely, we do this by helping them get informed, be prepared, and take action. There's a little bit more than 500 products that we've created to date in terms of core public educational resources. You know, this is everything from TV and print, radio, public service announcements, fact sheets, brochures, pop-up banners, discussion starters, even 4 original soundtracks, a podcast that is comes from our parents, what's titled What Parents Are Saying. And by the way, I'll put a pitch in. For those of you who are parents and caregivers and would like to come onto our podcast, we would certainly welcome that. We do, I think we have a little more than 18 episodes to date, and we do a variety of those, but also focusing on skill building and early intervention resources. Things like our mobile app, Parents Night Out, our Student Assistance Guide for Administrators, and a related webinar series, Screen for Success. Many of these things I'll talk a little bit more about in the next few slides. But all of these items are really there to align whatever we're doing in our messaging with an intervention for either schools, communities, parents, caregivers, schools, or communities. Now, you've heard me talk a little bit about student assistance, so I think it's worth noting just a couple of things. What is that? They've been around a long time, since the 70s. They have their roots in employee assistance programs. In the early days, those looked a lot more like a counselor of some type providing an assessment or doing some classroom presentations. They may have done a curriculum, but in those days it wasn't that popular. The important note here is that those things have evolved considerably over the last 3 decades. In fact, you will note that at the top of the screen there that it includes prevention services, therapeutic services, and support services, meaning broad support, recovery support, and lots of other types of support services. There are some components that researchers have told us that are pretty important to their effectiveness. Things like what we talked about earlier, school board policy, staff development, program awareness, having problem-solving case management teams, or a formalized internal referral process, making sure that you have sufficient direct services or at least access to community direct services so that you can do warm handoffs, making sure those programs are integrated and not just in the corner of some classroom or some part of the school that nobody really knows about. And lastly, things that I know many of in this group are very attuned to is making sure you're doing good program evaluation and continuously improving. We, as I'd said earlier, we have done a 5-part series webinar with folks in I think it was about 10 different states that came together to work with us to do this webinar series to talk about implementing a variety of types of student assistance across the board, including the last one, program evaluation. But everything from standing it up to how to, what the needs and assessment in a building, planning and implementation, experts all across the nation came together to provide that. It's certainly on our webinar and available to folks. And again, if there are different types of student assistance, there are some that focus purely on prevention, some that are more integrated, some that have a full spectrum of that, or some that just do more support services. No one version of that is necessarily right or wrong. What we really want to encourage is that you work within the limits of your capacity and do the best job possible for that function. Now, couple of things that are very exciting and near and dear to my heart as we talk about the intervention side. As it relates for schools and educators in particular, and you heard me talk about get informed, be prepared. So these are some of the things in the Talk They Hear You materials list, and I talked about a few of these. They're hyperlinked, so you can click on them and get to them quickly. I won't repeat all of that, but I do think that one thing that's worth just highlighting, and I love our discussion starters. Each one of them has an original song. I can thank Billy Joel's original sax player for Richie Kanata and his son Aaron, who wrote all of these songs for us. By Your Side is particularly near and dear to my heart because I'm a former K-12 educator running behavioral health programs, and it really speaks to that. But these discussion starters are designed to be the start of the conversation and to help you see why it would be important and where you fit into that spectrum. Now, what is particularly exciting to me is where we're going next. So you have all heard of SBIRT, and we're now sort of embarking on a next gen of that a little bit that skews a little more on the prevention side. Screening and brief intervention and referral for services. This is an action phase. And it starts with screening and early identification using our Screen for Success professional version, which is an organizational version. We are looking at 3 orders of intervention. First intervention is really just using motivational interviewing. The screening itself is actually the first order intervention. The second order of that is motivational interviewing and then motivational enhancement sessions, followed on by cognitive and behavioral sessions. And then lastly, that final order is the preparation, both for the individual, meaning the child or the adolescent, for a referral to services, but also the family. And in some cases, if it's done in a school, preparing the school for how they might think about and do that as well. Many times, folks with the best of intentions send a young person off to treatment and expect miracles when they come back, only to discover they've overwhelmed the individual and now relapse has ensued. And they're now trying to figure out what went wrong or blaming, either the other parent or the school or the treatment agency, none of which is actually helpful to the individual who's trying to recover. Now, you heard me talk a little bit about our Screen for Success. So we think of this as screening as a prevention strategy. It is oriented around screening for health, wellness, and well-being. We know that early and periodic screening is really widely recognized as one of the best ways to prevent the progression of more severe disease states. We screen for virtually everything else in the world, and many of us that are in my age group or younger have found ourselves being screened in various ways. And if you think about the purpose of those health screenings, whether they be prostate screenings or mammograms or any number of types of health and wellness screenings that we all endure, I say endure, that we all go through, it's designed to help identify elevated risk. And it really, helps us get ahead of cancer or other disease states that may be very problematic, diabetes, etc. The problem in behavioral health is oftentimes, and I think there's something a little more than, excuse me, 1,200 screeners. I'm not suggesting any one's necessarily better or worse. They're in most cases all validated, but most of them are a researcher's instrument. But what the real problem is, in my view, is that it focuses on one disease at a time, and that really creates a high burden for systems. So if you're looking broadly to do screening, if I'm looking for just one thing, I'm probably going to find whatever it is I'm looking for, but I may not be paying attention to the other things like health, wellness, meaning substance use, mental health, family functioning, well-being, meaning community connectedness, other kinds of things that would be helpful or impact success in mitigating. So that's where Screen for Success kind of shines in my view. That's this very same conversation I had with the research group that put this together for us. And that's when we came up with Screen for Success, which is a multidimensional screener, as I said earlier, health, wellness, and well-being. You can see on the screen what we're looking for. There are 60 items. There are 2 versions. It's about 7 to 10 minutes. Now, if you're doing it on a self-screening referral management purpose, which is what we refer to as the personal account, that's a parent or caregiver or concerned individual. You could do it with the child, which is going to take a little more time. You could send them a link if the situation calls for it and you're having hot communication issues. But it would allow you to provide an opportunity to try to get ahead of that. And even if it fails the first time, I would encourage people to try and try again, because what it really does is it shows care and concern, and that you're wanting to be present in that child's life. Now, in the organizational version, very different. So this is really organized system organization around screening across the system, whether you're a clinic, a coalition, or a state. We have a couple of states that are looking at statewide implementation of Screen for Success. But it allows you to be more organized. It also allows you to provide local resources as well. And I'll talk a little bit more about that, but just to show you some screenshots of what that looks like. The screen is pretty straightforward. We also have it embedded in our mobile app on the professional version. Like I said, it takes about 7 to 10 minutes. It's going to be geocoded to give you resources within your zip code. So if you're a listed treatment agency or provider in that agency, in that region, it's going to take you to that. It's going to allow you to download your results. So if you were doing the self-screening referral management, you might want to download that so that you could talk to a clinician and sort of be able to have that conversation more articulately, etc. In the professional version, as I said earlier, it also allows for localized resources, meaning as an agency, I could put those resources that are maybe curriculum-based or part of my program in place. As a state, I could put, I'll just use Connecticut as a great example, because the block grant doesn't really fund their substance use treatment, the Children and Family Services Group does. I might want to prioritize the programs and services that the state's paying for. Now, that doesn't not allow you as the user to see the geocoded resources that are available to you. It just gives you more state-focused services first so that you could use those and still have the option for other choices as well that might be in your area. As I said earlier, it's built into our mobile app as well. This really is the self-screening referral. But our mobile app was really our way of pivoting in the digital space so that we could get you, if you will, campaign in the palm of your hand. Virtually everything we have in the campaign is listed here, including an opportunity to practice conversations, to sort of rate yourself, to build up your confidence, do those kinds of things in a more interactive way. Now, I just want to share with you one particular piece here. Apologies, I thought I'd close those down. That may be useful to you to give you an idea of what the reports page looks like. So when you take and do the screener itself, it's going to put what we call the Screen for Success results out. And you can see poor Robert here was screened. We looked at him. He's a 16-year-old Caucasian male, all the usual things you'd probably see in a screener. We're going to talk about what popped up in family life, both strengths and weaknesses. You could click on that and you could get straight to family resources. At this point, what you're seeing is only the national resources that are associated with that. If this was a local implementation, you would see those local resources. But you can click on any one of those and get there. But to my point, so this one was done, I think, in Washington State. Yep, it was done in Washington State. So you can see those resources and you can just keep expanding out until there are no more resources in this particular area. This is resources near me for families. You'll get the same. I actually found my own physical therapist through this app, but you could do the same here in terms of health-related tools. It will do the same in substance use and give you agencies there, and you can see where the download piece goes there. You can also click this resources page, and that's going to take you to the Screen for Success national website. And this will be all of the national resources, but you could also just search for other resources that may exist out there in any of those domains that have been flagged. When you do the screener, it will link whatever you flag and looks like you might need, wherever you demonstrate elevated risk, it's going to provide a potential resource for that. And so this will be some examples. We're not finished populating all of this, just so you're aware, but we continue to populate it every day. Again, we're still a little ahead of implementation, but you can see the kinds of things, and you could just continue to search and find other resources that fit your bill, including we have an item in there for suicidal ideation and psychosis. And should you actually need to dial 988 or get some immediate help, we made sure that you could do a click and link to straight over to the 9888 system. So let me stop there, and I will just open it up for questions and comments, thoughts. I've got pretty thick skin, so don't feel afraid if there's a criticism. I'm not afraid to hear it. So please feel free.
Rob, that was fantastic. Thank you so much. And I just want to encourage everyone on the call to not be shy. If you like to put a question in the chat, please feel free or raise your hand.
And I always love to see people. So, please feel free to come on camera and have a conversation.
Hi, my name is Tammy Cooper Woodrich, and I'm a voc rehab counselor in Bellingham, Washington. I was just wondering how receptive the schools were for any type of assessments, like even the self-assessment that you just mentioned. I know sometimes confidentiality is a big issue with all the new HIPAA laws and things, so I just wondered how receptive the schools were.
So in the state of Washington, if you'll go down to Olympia, where I was, Educational Service District 113, I think they're now calling themselves Capital Educational Service District, but you will find that ESD has been doing for 27 years, full-on screening and assessment, and has a very robust, and that's happening now across the state in all 9 of the ESD regions. To your point, you're right. Schools have some concerns sometimes about that. We have taken, so you need to know what drives the privacy. First of all, we've got an IRB, OMB packages, all of the kinds of human protections you could possibly imagine. What we did here, maybe differently than sometimes happens, is we took the highest level of protection possible. So I'll give you an example. You could be my mom, and you could have sent me the link to fill out the screener, and I did, but I don't have to share that information with you because it's my choice as a child. And some would argue that the parent needs to know. I understand that, but I would also share that in the event, and this has certainly happened to me, and let's use an LGBTQ child who hasn't come out to a parent, and all of a sudden those are some driving issues, and I come out, and perhaps I have a father who is not very understanding of this, in fact, maybe hostile. There's a chance that I could harm that child just by virtue of that action. So we put the child and the parent in charge of that. Now, that said, our protocol is we're encouraging conversation. We're encouraging you to start doing that. And that really is the real goal, is to encourage parents and caregivers. And the child will be the gatekeeper, as would the parent in many instances, depending on the conversation of the information. But it is protected. It is housed, just so you're aware of, from clinical perspective, the Chestnut Health Systems, which is doing this work in 17 countries all across, and is, Dr. Michael L. Dennis is an NIH researcher and has been doing that for a very long time. So it has been protected to the highest level. And to your point around schools, we understand that. What I don't encourage when people think about schools is trying to mandate anything. You have to come into it to your own, so it's an encouragement kind of process. Do it should you want, which is why we have the self-screening and referral management. Because what you could do in that view is you could just simply say, listen, we recognize there's some things here. We as a school are not comfortable in doing that work, but here's a resource that you could do that for yourself. And I hope that answers your question. If not, feel free to send me an email. I will make sure my email is available and happy to answer additional questions.
Other questions from the audience?
Oh, I see Nataki, my friend Nataki over at ONDCP.
Yes, good afternoon, and I apologize for not being on screen, having some technical difficulties with my video feature. Two questions I just wanted to ask. Robin, I know you've been doing this for a long time, so this is just a question for the sake of discussion. You mentioned a good point when we say we're trying not to get schools to act like they have to become behavioral health providers. So it's really about creating the partnerships so that educators can educate and behavioral health folks can do what they do. So can you share maybe some best practices of how to help folks negotiate the partnership between the schools and providers to do the work of prevention and intervention for youth?
We took some care and time to produce an administrator's guide for student assistance that really takes head on this very topic. What are the predominant three models? What's the merits of those three models? How you could best use them, what you should be thinking about if you're a school administrator thinking about this, because it's something more than just hiring the local mental health therapist or substance use provider to come into your school. You need to be thoughtful about how you're going to do that, what's required, what's involved, which is why you heard me talk about the components of student assistance and some of those kinds of things, because you could hire that person, drop them into a school, and largely the resource go underutilized. Now, in terms of creating partnerships, so in the three different kinds of models, an internal kind of model, which could be prevention only, or it could be a combination of therapeutic or care coordination, sometimes it turns out as well, where you're using somebody more in a coordination role, which is more like the Pennsylvania model, or what they call care teams. Sometimes schools, and I know this all too well. I was a former teacher, an educator, and clinician. I've kind of been on all fronts of this conversation. Schools can get very insular very quickly. And usually that's out of fear. Fear that they don't have the resources, the know-how, or the understanding. So if you're a behavioral health provider, you need to take care in how you approach school leadership and administration. You need to be a true partner. As a school, you need to take time and care to really think about what you're trying to accomplish. I love my educator friends, but they're known widely for just grabbing on to the latest thing, dropping it into their school, and then going, wow, it didn't really work out very well. I wonder why. And that's as much of a problem as anything I can imagine, because the biggest crime I can think of is that there's a resource available to a child that is underutilized or not utilized. And now we've taken a professional's time and wrapped it up in a situation that somebody else is now unable to utilize. And so sometimes we don't always think that through, which is why we wrote the administrator's guide. But I would really encourage you to grab that guide if you're interested. And I think it walks through those kinds of things. Our local community coalitions, which ONDCP is very aware of, can serve as very active roles in all of that, helping to bridge the gap between clinical providers and the school building. So sometimes they serve an amazing role in that space.
Rob, there's a question in the chat from Joan Romaine. Do any of the assessments or interventions include assessing for spiritual or religious supports, coping, etc.? Or spiritually based CBT, if appropriate, with a student?
We did not, only because it's being sponsored on the Fed side. So you know how this kind of conversation goes sometimes. Now, that said, there's nothing in there to prevent an individual from using this as a starting point and going forward. But to your point, I mean, people would have known, people have heard me say, please don't use Screen for Success as a universal screener. Well, that's kind of a yes and a no. Because if I were running alternative schools, which, I ran some, every kid that came to my alternative school got screened. And they got screened because we knew they were coming to us because they were a priority population. There was some elevated risk for them. We needed to make sure we addressed all of their needs so we could be better educators. But there isn't specifically as it relates to the spirituality piece. Now, all that to be said, there's nothing to prevent that. In a future iteration of that, we will make Screen for Success so that you could add additional modules to the screener. So you could have, if you were the type of organization to do that, something that was, related to spirituality and those kinds of things that would better suit your needs. We haven't done it yet. Again, we're still a little early. But it is that question has come to us before, and we wanted to try to make sure that we had some space to account for that. We just haven't done so yet.
Wonderful. From Tiffany Hall, do the screenings count as an intervention in terms of needing consent? In Alaska, children need parental consent under 18 for mental health services. If it does count, can it be reimbursed prior to diagnosis? Maybe that's a state level question, not national.
Well, it's a combination of both. The short answer is so state laws vary widely. In the state of Washington State, I think it is either 13 or 14. I can't quite remember. One of my Washington colleagues may have this off the top of their head, where you can elect independent health care for anything that's non-invasive. And that same protocol varies widely across the US, right? So we have made where you have to consent and assent, meaning the adolescent, at every step of the way in this. So to answer your question, yes. And it is reimbursable. You also know that the dollar amount, I think it's $13.50 per screening is what the reimbursement rate is for Medicaid. It's not a lot. But that said, you could in fact do that. My friend Kate Guinness, who is over at CMS, and I've had some conversation around what that could look like. I've asked her to look at it, and she said there's no reason that it couldn't, but even in terms of EPSDT, you could actually use the system in that same frame if you were thinking about early periodic screening, detection, and treatment in one of those. Although that system, depending on how your state has deployed it, may or may not require it to be driven by a physician or a physician's office or a healthcare entity. So it just depends on your configuration, but in theory, you could in fact use it in the same way.
Excellent. I think we have time for at least one more question. How often do you see poverty as an issue in those screened?
Routinely.
Tammy Woodridge.
Yeah, Tammy, routinely. We know social determinants of health matter. We know poverty in particular is a challenge. Low resource communities, or I hate to say it quite this way, but communities that are often forgotten or sort of I don't know, disparaged, if you ask me. I mean, that's a strong statement, but there are communities that I think have felt that across our nation. It's one of the reasons why we tried to make this as digital, as portable, and as available as we possibly could. It's free. Anybody can use this system free of charge for any reason. You're either a covered entity or an uncovered entity. And if you're a covered entity, then you know what your HIPAA laws are and what's going to be required there. If you're an uncovered entity, then we sort of read you, this is the limitations and how you need to think about that. And you should be warned that, if you're trying to do things that you're unlicensed for, that's not helpful. But screening is not a diagnosis. And we've been very careful in that frame that we're not here to diagnose, although the instrument the instrument actually has the capability. It has over 1,000 research papers against the measures that we've used here. It's been deployed in 17 countries worldwide and been used for, I think the latest data set, clean data set that Mike's publishing against is well over 1 million plus records. That said, we really are just encouraging sort of appropriate use, trying to give people the limitations of that, trying to help them think through what that could look like, what that should look like. But it doesn't take a license to screen, and you could be a layperson. That's why we do the self-screening referral management. It's not required. The object here is not, the goal here is not to render diagnosis, but to look for elevated risk and help you access resources, whether it be preventative or therapeutic or ongoing support, to help you resolve your issues, and really put you in charge of that.
Well, I am so sorry that we have reached the end of the hour. I want to encourage people who may still have a question to enter those into the chat. Rob, would you be agreeable with?
Absolutely. Please feel free to send them. I promise you I will answer every one of them. Be aware I do have a day job, so just, be mindful. But that said, I promise you I will answer all of them. And if I can't answer it, I have a wonderful team of researchers and folks that are so much smarter than me. I'm just a guy trying to solve a problem. That I can connect you with and include you and if I don't have the answer, I know somebody who will. So
that's wonderful. Well, we're so happy that you are there as a resource for us and solving a lot of problems. I think you're being very humble, but those of us who have had the privilege of attending some of your programs before know what a wealth of information you have and how helpful you have been. Lifting up the health of our communities and of our children in particular. So thank you so very much for that incredibly rich presentation and thought-provoking presentation. And thank you to everyone who joined us today. We hope and trust that you found much in Rob's presentation today to help you in the work that you do day to day to lift up our children, all of whom are a priority population for preventing and intervening with mental health and substance use problems. Today's webinar was recorded, and a link to the recording will be available on the NIAAA website under the tab for the Interagency Work Group on Drinking and Drug Use in Women and Girls in a few weeks. In the meantime, please be on the lookout for the announcement for our next webinar coming up in December, and that will focus on intervening with young women and adolescent girls who are, I know you don't like this term, but Rob, at risk and living with mental health, but they are our priority. All of these children, young people are our priority. So have a wonderful weekend, everyone. And until we're together again, we wish you all continued safety, vibrant health, and peace. Thank you for coming.
thank you, everybody.
Bye-bye.
Bye-bye.
Rob, can you stay on for just a moment?
I will, and I will send you my PowerPoint. You're free to share it with anybody you wish.
Fantastic. That was one of the
I
questions for you.
Yeah, and I'm happy to share it. I just apologize. I just couldn't get the team to update a couple of data slides just because they're special run data slides for us. So that always takes a bigger minute than I can usually get when I want it. So.
Well, thank you for thinking of that. I just mainly want to thank you again. That was amazing.
Well,
It was the last time that you were with us, so full of helpful information, very practical information. And I do want to, I'm sorry, I was distracted for a moment.
no worries.
Thank
Totally
you.
understand.
For inviting me to participate in ICCPUD. I'm going to do my best to take you up on that invitation. And if there is anything else that we can do to support the work that you're doing at SAMHSA, here at NIAAA, we're happy to do it.
Well, I know we're having conversations with George on doing some additional work. I know I'm trying to put something in the chat. There we go. Apparently, I'm just having a problem here. It's just me, apparently. Let's see if I can do this differently. There we go. Finally.